Hi everyone, I am Dr. Sharad Balaji here. Today let's discuss about an important aspect in pediatrics office practice, that is Bcg adenopathy, how to deal with it. There are so many myths and mysteries behind this Bcg adenopathy. Let me try to demystify or decode these things based on my personal experiences with 64 odd cases of Bcg adenopathies in our center. Before going to the topic per se, let's have a basic look about this BCG vaccine. It is stored in an amber colored bottle and it is stored in the first compartment just below the freezer because it is extremely light as well as heat sensitive. We often use normal saline as a diluent and it is injected over the left arm just below the insertion of the deltoid intradermally. Catch-up vaccination can be given up to 1 year as per Indian immunization schedule, but as per Indian Academy of Pediatrics, it can be given up to 5 years. When you give BCG vaccination, what are all the expected reactions? By about 2 to 3 weeks, you will get a small papule which increases in size by about 5 to 6 weeks. Finally, they will form a blister which ruptures and form a permanent scar over the left upper arm. Almost majority of Indian people have this BCG scar. Is BCG vaccine mandatory in our country? After having living in India, an endemic country for tuberculosis, you can't question the credibility of BCG vaccination. Whether it prevents pulmonary tuberculosis or not, it definitely prevents disseminated form of tuberculosis such as tuberculous meningitis. Right, case 1. A 9-month-old child brought by her mother for MMR vaccine and she noticed that her child doesn't have a BCG scar. And the mother told that she also did not have any BCG scar and she developed tuberculosis when she was young. So she was thinking that absence of BCG scar means absence of immunization and the child is prone to develop TB. Is it so? What are all the facts, myths and mysteries behind it? Remember how frequently absence of BCG scar is seen after a BCG vaccination? 10% of Indian population, they do not develop BCG scar after BCG vaccination, and overall incidence in the world is around 8.6%. Does it mean absence of BCG scar means it is vaccine failure? It is not so. In majority of them, those who did not develop BCG vaccine scar, it is found out that they develop immunity, T cell mediated response after the vaccination. It is proved by lymphocyte migration inhibitory response. So what does it mean? If the mother still wants to have a repeat dose of BCG vaccine, what is the advice as per National Advisory Committee for Vaccination? If there is no BCG scar, even after 6 months of BCG vaccine, a second dose of BCG vaccine can be given. Remember, for a second dose, it doesn't mean that you need to put a manto or an IGRA. You can just go ahead with your BCG vaccination. But even after the second dose of BCG vaccination, if there is no scar, do not go for the third dose. So can I give second dose of BCG vaccine for those who doesn't develop BCG scar? The answer is yes, you can. Right. Catch-up schedule, as we discussed already, those who are not sure that the child received BCG vaccination, it can be given up to 1 year or it can be given up to 5 years as per IAP or as per Indian Academy of Pediatrics or National Immunization Schedule. Some countries have been following booster doses too. Case 2. Look at this BCG blister. A 3-month-old child brought with the BCG blister. Is there any role for incision and drainage? Is there any role for antibiotic? What treatment should be offered to this child? Is there any role of incision and drainage? Abscess, BCG blister, frank pus. The answer is no. There is no need for incision and drainage. You just observe. It will break on its own to produce a permanent scar. Is there any role of antibiotic? Unless otherwise, there are signs of acute inflammations like rubercular, dollar, redness, everything. There is no need for routine antibiotic in BCG blister. So what is the treatment of choice? Just reassure the parents. This is case 2. Then comes case 3. Look at this. BCG adenopathy. Look at this. A cicatricial scar. Look at this. A huge swelling in the left axillary node. A blister adenopathy that is going to rupture, impending rupture. A supraclavicular site is involved. And finally, a child with excavated BCG scar along with an ulcerative axillary lymphadenopathy. Look at this. All these are various avatars of BCG adenopathy. Right. To say whether it is a BCG adenopathy or not, that adenopathy should satisfy certain criteria. What are all they? It should be over ipsilateral axillary. It can be over supraclavicular. Rarely it can be due to lower cervical. I repeat, we have seen cases of supraclavicular as well as lower cervical adenopathy. But remember, it should be ipsilateral over the same site of BCG vaccination. Previously, it was thought that because of giving subcutaneous rather than intradermal and because of giving above the level of the deltoid instead of giving below the level of the deltoid, people was thinking that BCG adenopathy had developed. But in this era of Mendelian susceptibility to mycobacterial diseases involving interleukin-12 interferon gamma pathway, I personally doubt that each and every case of BCG adenopathy should be investigated for this interleukin-12 interferon gamma pathway defect. Right. And as we discussed already, there should be a preceding same site vaccination. Usually in our cohort, we have seen cases, majority of them develop BCG adenopathy between 4 to 6 months of age. But at times in 2 to 3 cases, they develop BCG adenopathy. Even they can go up to 2 years. Then later the period of BCG adenopathy or later the identification of BCG adenopathy always leads to diagnostic confusion, whether it is acquired or it is due to BCG vaccine per se. Case 3. This is an 8-month-old child. Look at this, birth weight is 3 kgs. Present weight is 8 kgs. It is a 5.5 firm swelling over the left axilla, otherwise normal. Someone did a CB0, turned out to be positive, and they did Manto, turned out to be positive. They told that their father took ATT 4 years back. Is there any role for ATT here, antibiotics or IND? Look at this, the weight of the child is 8 kgs at 8 months. It means that there are no constitutional symptoms at all. It virtually rules out it is an acquired tuberculous lymphadenopathy because it is more common in cervical rather than axillary. So it is presumed that it arises from the left axillary node. And also you can say, how can we differentiate whether this BCG adenopathy is due to BCG vaccine or acquired from his father? Very simple. BCG adenopathy, the strains are inherently resistant to pyrazinamide. So all BCG adenopathies are resistant to pyrazinamide, but literally based on good clinical history, we don't do such test in our day-to-day practice, at least in our center. So CB0 positive, Manto positive, what does it mean? It is the BCG live attenuated vaccine that produces these kind of BCG induced adenopathies. What is the treatment of choice? Is there any treatment with ATT, adenopathy, antibiotics or IND? Let's see. Look at this. This is a firm non-fluctuant BCG adenopathy. What is the treatment for this non-fluctuant BCG adenopathies, otherwise called as non-suppurative BCG adenopathies. Majority of them regress spontaneously over a period of 6 to 8 months and 30% risk of suppuration. Needs a close follow-up, and there is no role for ATT or antibiotic. If there are no signs of acute inflammation, don't give antibiotic. If there is no failure to thrive or constitutional symptoms, don't start ATT. So non-suppurative BCG adenopathy, just observe, it will regress on its own. Look at this case 4. There is a 1-year-old child with a birth weight of 2 kgs and a present weight of 9 kgs, swelling in the left axilla for the past 4 months. It is fluctuant and there is an impending rupture is visualized. Again here also CB0, someone did it, positive. They did an FNAC which showed caseation. What next? ATT, antibiotics or IND? So what is this? This is suppurative lymphadenitis. What is the management protocol for suppurative lymphadenitis? Remember, see whether it is a thick pus or thin pus. If it is a thick pus and there is matting, multiloculated, it should be removed in toto. Remove that node in toto. Whereas if the never ever tried to do an incision and drainage, in our personal practice, in our cohort, the children who had undergone incision and drainage, the more and more chances for cicatrization. Even though our NTEP guidelines said IND can be done, in our personal cohort, we found that there are more chances for cicatrization when you go for incision and drainage. So a kind request to all our friends, whenever you send these cases to your pediatric surgery colleagues, tell them to remove the node in toto and not to go for an incision and drainage. Then if it is a thin pus, repeated aspiration is more than enough. Repeated aspiration is more than enough. And I repeat again, the more and more you do an incision and drainage, the more and more chances for cicatrization scar over the BCG adenopathy site. Right. In those cases which we have discussed already, the present weight is good, appropriate for age compared to the birth weight. But in this case, this is a 10-month-old boy, birth weight is 3 kgs, present weight is just 6 kgs. And he has constitutional symptoms like fever, cough, weight loss, which has been there for the past 3 months. With organomegaly, X-ray shows bilateral patches. What next? Look at this. Look at the scar. Look at the excavated BCG scar. Look at this excavated BCG scar and an ulcerated BCG adenopathy with thick pus. Look at this. Whenever you have this excavated BCG scar, you always need to think an underlying immunodeficiency, because beware, this is BCG is a live attenuated vaccine. So what you should do? What is the next step you need to do? Almost majority of these cases who developed constitutional symptoms like fever, cough, weight loss, organomegaly, along with this excavated BCG scar, are found to have severe combined immunodeficiency. A simple clue for severe combined immunodeficiency is do a CBC and look for an absolute lymphocyte count. In infants less than 1 year, an absolute lymphocyte count of less than 3000 should be considered as severe combined immunodeficiency unless otherwise proved. And you can do an ultrasound to look for presence or absence of thymus. Then you can go for lymphocyte subset analysis too to confirm your diagnosis of severe combined immunodeficiency. Right. So this is a case of SCID presenting with an excavated BCG scar as well as failure to thrive and constitutional symptoms. Our next case, we have learnt a lot from this case in particular, and she is a 12-year-old girl. At 4 months, she developed Bcg adenopathy, took ATT for about 4 months. It was started elsewhere. By about 4 years, she developed a persistent oral candidiasis for about a month, settled with some treatment. Thereafter, the child is absolutely healthy. By about 12 years, when the child came to us with pulmonary tuberculosis, R sensitive, rifampicin sensitive, isoniazid sensitive. So we started her on HIV negative. So we started her on ATT. But after 2 months of good compliance, good sensitivity, as well as good oral availability, the child developed miliary pattern of TB. We really didn't know, is it a paradoxical reaction? A paradoxical reaction usually will have an initial improvement followed by worsen. But here the constitutional never improved. Since there is an associated Bcg adenopathy and associated oral candidiasis, we were suspecting a pathway defect in the pathway involving interleukin 12 and interferon gamma. Surprisingly turned out to be a case of Mendelian susceptibility to mycobacterial diseases. Remember, this case was almost asymptomatic after a period of Bcg adenopathy. Right, so MSMD presenting at 12 years of life. Right, when to suspect BCGosis? As we discussed already, an unhealthy, excavated, large BCG scar with Bcg adenopathy, sometimes generalized lymphadenopathy, constitutional symptoms like fever, cough, weight loss, etc. Always, whenever you find this kind of scenario, it indirectly tells that there is an underlying defect in T cell phagocytes or interleukin 12 interferon gamma pathway. Right. Right. Then, okay, how can I suspect? What does it mean? Once again, how can I suspect these underlying risk factor? So BCG is a live vaccine. When you give live vaccine, if there are underlying SCID, CGD or MSMD, there are high chances for the child to develop BCG adenopathy. Once the child develops BCG adenopathy, it is very, very difficult. When you give ATT, you need to go for bone marrow transplant. Till then, it will be difficult. So how can I suspect these underlying risk factors so that it can predict the child can go for BCGosis? The answer is very simple. Make it clear. Any infant with persistent or recurrent pneumonia with failure to thrive, always look for 3 things. What are all those 3 things? An absolute lymphocyte count of less than 3000 cells per cubic millimeter, absence of thymus in chest X-ray and ultrasound neck. Second, extreme neutrophilic leukocytosis and abscess formation. So the first one indicates an underlying severe combined immunodeficiency. The second one indicates chronic granulomatous disease. So what does it mean? Before going for BCG vaccination, just ask whether there is a family history involving death of the child in the first year with a similar BCG large scar, or a child died of recurrent or persistent pneumonia or diarrhea, because it can indicate an underlying SCID. An abscess formation in a child, recurrent abscess formation, lymphadenopathy in the previous sibling, again points in favor of a chronic granulomatous disease. Third, look at this. Similar history of BCG adenopathy in family members. Recurrent TB despite sensitivity, good compliance, good bioavailability. Whenever you get recurrent TB, often people used to think that in adults it can be due to an underlying HIV or underlying diabetes mellitus or underlying acquired using immunosuppressive drugs. But without having all those risk factors like HIV, diabetes mellitus, immunocompromised status such as receiving TB or some other drugs. Despite good sensitivity, good compliance, if an adult also developing TB again and again, kindly think in terms of an Mendelian susceptibility to mycobacterial diseases. I repeat, right? So ask these three things. Previous infant died of persistent pneumonia in the first year. The previous infant died of recurrent abscess or persistent pneumonia or osteomyelitis. Family history of recurrent TB despite absence of risk factors like HIV, diabetes or under immunosuppressive drugs. So beware of these risk factors before proceeding for BCG vaccination. So what is the carry home message? BCGosis means it can be either severe combined immunodeficiency, or it can be chronic granulomatous disease, or it can be Mendelian susceptibility to mycobacterial diseases. Our cohort, 64 cases so far, boys 35, girls 29, non-suppurative 30, suppurative 18, one which initially was non-suppurative, then suppurative 9. We have around 7 cases of BCGosis, SCID 3 cases, MSMD 3 cases, and chronic granulomatous disease 1 case. So what is the carry home message after this discussion? For a non-suppurative BCG adenopathy, just observe. For a suppurative BCG adenopathy, repeated aspiration. But if there is a matting or failed aspiration, go for excision in toto. Never try to do an incision and drainage, as we discussed already, which can go for cicatrization scar. If there are failure to thrive plus systemic manifestation, it means BCGosis rather than a simple BCG adenopathy. So you need to look for an absolute count to confirm or to suggest kit, to look for extreme neutrophilic leukocytosis in a child with a recurrent abscess, which can suggest chronic granulomatous disease. Family history of BCG adenopathy, recurrent TB, despite absence of risk factor, will make you to think in terms of an MSMD. So what does it mean? Always before vaccinating any of your child with BCG, ask for sibling death within a year due to pneumonia, recurrent TB in family members, or presence of BCG adenopathy in family members. I don't know whether in our cohort there are so many cases of severe combined immunodeficiency. I don't know whether do we need to do a simple cord blood to look for an absolute lymphocyte count, to look for an extreme neutrophilic leukocytosis, and to ask for a history of BCG adenopathy in family, so that BCG vaccine can be avoided in under these circumstances. So with this, I am finishing my topic. Bye-bye.